All right, friends, it's time to give you loyal listeners a discount on protein powder. You may or may not know, but I launched my very first protein powder 2 years ago. It's a grass-fed beef isolate with only 3 ingredients: grass-fed beef, either organic cacao or organic vanilla, and organic monk fruit. Now, if you don't want any of the added flavor and sweeteners, you can also just get unflavored. And no matter what flavor you choose, you're getting over 23 grams of protein per scoop, which is going to keep you full and satisfied between meals. I love starting my day with a Fab4 smoothie and breaking my fast with that much protein. It makes a serious difference in my cravings and blood sugar balance the rest of the day, and I've seen it with my clients as well. Now, I never thought I'd own a product company, but when I got pregnant with Sebastian, I realized the majority of protein powders were chemically extracted or enzymatically extracted, and I wanted to use heat and water only. I wanted minimal ingredients because we don't need those emulsifiers, fillers, or added vitamins, minerals, and probiotics. All of those additions increase the chances that it's not going to work for your body, whether it be bloating, digestion issues. I just wanted pure, clean protein to keep you full and satisfied so you could build the most delicious Fab4 smoothie. And I have to say, I'm pretty proud of the flavor. If you take a look at our reviews on Amazon, you'll see 5-star reviews for flavor. And that is key, because if you don't love your Fab4 smoothie and you don't love drinking your protein powder, you're not going to do it. It won't become a habit, and it's consistency that outpaces everything. So if you're here and you're listening and you want to give our protein powder a try, use the code PODCAST5 for $5 off your order. And let me know if you love it. My favorite ways to apply this protein powder is in my Fab4 smoothie, making freezer fudge, making chocolate milk, making hot chocolate, and throwing the unflavored into all my kids' baked goods. So let me know how you use it. Let me know if you love it, and share this podcast deal with your friends. Welcome back to the show. Today is a very special episode. We are celebrating 3 million downloads in less than 15 months. So before I introduce you to today's very special guest, I want to take a minute to thank each of you for having me in your ears every week, for sharing this podcast with your family and friends, and for reviewing it online. The Be Well by Kelly podcast has quickly become my favorite medium. I feel like I can be myself, and it's been so fun to have my friends, authors, doctors, and entrepreneurs on the show. The goal of the show is always to help you learn, grow, feel inspired, and mostly just to have fun. And today is no different. I'm celebrating by sharing Taschen's birth story with my board-certified OBGYN, Dr. Lisa Karamardian. Dr. Lisa Karamardian received her medical degree from USC, where she graduated as a Dean Scholar. She completed her residency at LAC, USC Women's and Children's Hospital, and is highly skilled in high-risk pregnancies and deliveries. Lisa practices in Newport Beach, California, and is a staff member at Hoag Memorial Hospital and has been since 1996. She has received the Orange Coast Physician Excellence Award multiple times and has been named in America's top OBGYN listings. What she might not tell you, but I might, is that she also has delivered some of our favorite NBA All-Stars babies, past and present, and has the biggest heart on the planet. She has healed both Chris and I from the inside out. So without further ado, it is my absolute pleasure to introduce you to Dr. Lisa Karamardian. Dr. Karamardian, I'm so excited for this episode. We have been trying to connect and make this happen, and I'm obviously just coming out of trimester 4. So I'm so glad that we are able to connect and talk about Taschen's birth story, which was such a healing journey for me. And the whole experience with you is just absolutely wonderful. I love you more than anyone. And I'm just so thankful that you're willing to spend some time here today.
I'm excited too. I know it's been a long time in the coming, trying to kind of coordinate our schedules and stuff, but it's fun to sit down and debrief afterwards and to go over things, talk about what went great, talk about what we can do better, and just kind of celebrate what happened. So yeah, I'm excited.
I love it too. And you were equally as busy delivering twins last night. And so I'm glad that you got a little rest before this call. And I'm sure that mom was just as thankful as I am. Twin births vaginally last night.
Yes.
So many positive birth stories coming out of your practice and your office. It gives me the chills to think about. And I'm I'm grateful for you. So thank you.
Well, it's what keeps us going each day. It's exciting. I mean, it has its highs and its lows, but it's really kind of why I chose this field and stuff, because you really get to connect with your patients and share some incredibly intimate moments, So
it's the most beautiful day for so many people. I mean, my husband might say it was our wedding, and I might say it was the birth of my children and then our wedding. But let's start with your story before we jump into the birth story. How did you decide to be an OB, and where did you go to school, and what inspired you to have these intimate moments with women?
Well, okay. So I started off at USC, and partly that was, I was raised in a pretty conservative Armenian family, and one of the first women in my family to go away to college. And so it was important for my parents that I stay close to home. I debated between Stanford and USC, and my parents kind of encouraged me to go to USC because they just wanted me closer to home and stuff. And it turned out to be an amazing experience. I did all of my training there. And I think for OB/GYN training, I couldn't have gotten anything better than that. I trained up at the big county, as we used to call it. And at Keck USC, it was the largest teaching hospital in the country. And so literally saw everything that you could possibly imagine that had to do with labor and delivery and gynecology. So, from malaria and pregnancy and any kind of crazy stuff that would come through the door. I trained during the time when it was kind of the last before Medi-Cal deliveries could be done in outside hospitals. So we literally had the largest volume of any training program around too. So in my, internship year, I think I did over 4,000 deliveries myself as an intern. And so really getting that volume and that experience that you just really couldn't see elsewhere. And then on top of that, aside from the volume, is just, the ability to kind of have a lot of autonomy that you don't necessarily have that early on in your career. So it kind of teaches you to be the captain of the ship and, to make those kinds of decisions and stuff. So it was a great choice and one that I was excited to have. I chose this field because I think in any other medical field, if you do a really good job and you treat your patients, then you no longer see them anymore, and they go on from whatever that problem was. But OB/GYN was unique in the fact that it was more like one of the surgical specialties where you got to do exciting procedures, or say in this case, deliveries for your patients, but then you still follow them for their entire life. And, you get to build that relationship. And so for me, I'm now hearing, and seeing some of the girls that I actually delivered myself and now delivering their children. And so it's kind of amazing to be a part of that longevity and to have that whole history with those families. And that's really what I enjoyed and why I chose this particular field. So it's more like, getting together with girlfriends every time I walk in the room and sharing and, just like today, being able to sit and talk with you. And that's kind of priceless.
It is, to follow the full circle of life and to be delivering babies that you've delivered, children. Like that's beautiful. And I hadn't even realized that you are in one of those fields where you just get to spend so much quality time with
You hadn't realized how old I am, Kelly. That's why.
No. And I do want to highlight what you said earlier is you had so much work at Keck USC and autonomy that you became the captain of the ship. And that was something that I noticed right away. I mean, I have very close girlfriends that I went to high school with. And even earlier in junior high and elementary school, that when I made my way back down to Orange County, they could not recommend anyone but you, and they all go to you. So they knew my past and they knew my story, but I needed someone to captain my ship. I needed someone who kept up with the research, who knew what we were going to do to make the story be different this time around, who really would be the boss. I think a lot of times when I work with doctors, because I collaborate with them so often, we become more friends, and then they're weighing in on what I want, maybe a little more than they should. And you right away in our first appointment, when I went through Bash's birth story, you were the captain immediately. And I think that for me was a safety net and a security. It was like my life vest. And I can't thank you enough for just taking charge and being like the OB mama bear for me, because I don't think that this story would be as beautiful as it was without you just going with your gut and taking over. So first of all, I just want to acknowledge that. Thank you for doing that for me, because we need that. I think a lot of us come in with these big birth plans and we want things to go our way. And for someone who knows that it just doesn't always go the way you planned, that taking a back seat in this kind of a medical delivery situation can be to your benefit. So I want to encourage so many people listening, if no matter where what kind of birth story you want to have, you want a natural at-home birth, you want to have a hospital birth, you want to have an epidural hospital birth, a natural hospital birth, an epidural hospital birth, a C-section. Like, I think we need to feel empowered to do what's right for us. But I do think that there is a little bit of a groundswell in the wellness community that there's a right way and a wrong way. And I kind of want to demystify that. I want to bring it back to the beauty in safety and having just a beautiful, healthy child on your chest. So
yeah. I so appreciate you saying that. I think the hardest thing for OBGYNs is to kind of listen to all of that fear that's out there, and to really, and whether it's been established in the media or whether it's, other factors, just this feeling like you have to have a relationship where you know that individual has your best interests at heart and is going to do what's best for you. And you want to take advantage of my years of experience and training and stuff like that. That's not to say that I'm not going to take some of what you want into account. I'm going to try to accomplish what you said. What are the different goals that you have? But I tell patients, especially when they come in with this plan, I mean, that in and of itself, just the fact that everybody thinks they have to write their birth plan sets up some kind of a false kind of expectation that this is something that we can plan. And you can't always plan what's going to happen. What you have to do is in the moment, do what is best for each step that comes along the way. And that can only happen with years of experience and training and being able to communicate to your patient. And hopefully you have a relationship of trust there that you can understand. And even someone like you, who's highly educated in the medical field, to say, okay, this is what I wanted, but this is what's best now. And I think the part that got to me, I mean, when you came in, a couple of your friends had said, oh, my friend Kelly's going to come see you. Yeah. Oh, we'll let her tell you what happened the first time with her, delivery story. And I knew there was going to be a story there, but I think when I listened to you tell me your story, I think the part that got me, and I felt so emotional when I heard, is I could see how things unfolded. And I could see where, you showed up and probably had a plan for what you thought was going to be your first delivery journey. And I think after years of OB/GYN experience, you realize that none of this is planned. None of this can be, planned out in a perfect scenario of what you want. And I mean, I joke to patients all the time in the room, if I could plan things, I would run more on time and you wouldn't be waiting for me, because each room I walk into, you don't know what's going to unfold. And so just understanding that and realizing that, this is not a planned sort of a field, but it's one of those in the moment. You have to be, you've got to be able to quickly shift directions at a moment's notice, but always recognizing that the ultimate outcome is healthy mom, healthy baby, and weighing what's the right decisions to make to keep both of those, intact. And so it may not always be what you initially thought was going to happen, but what you want is that outcome in the end. And it's a balance. It's a balance, but there has to be a sense of trust there.
Oh, and I felt so much trust with you immediately. I obviously had a lot of fear coming from coming out of Bash's birth, I wanted to make sure that our second child, we didn't know at the time what it was going to be. Our second child, Taschen, our little boy, second little boy, I just wanted him on my chest. I wanted that skin to skin that I didn't have with Bash. Sebastian was put in an ambulance and taken away from me. And I look back on that first birth and I tell that story in a different episode. So if you guys want to listen, you can head back. But I remember telling you that I had spent 16 hours laboring without an epidural, and to the point where I was shaking and really not in a good place. And my OB at the time was like, if you want the vaginal birth, you need to consider the epidural. And I think we need to be willing to pivot from our plan is, I think, the most important lesson that I learned was exactly what you said. You're the expert, and let the expert be the expert in regards to keeping you safe and your baby safe. And in hindsight, when I look back, I think to myself, if I knew I was in a fear state when I got to the hospital, I think I thought I had prepared with hypnobirthing, and looking back, maybe I should have done the Bradley method because I love science, just to understand what's happening in my body. There are different ways to achieve that, but I wish I would have.
See, Kelly, even there, I feel like you're trying to understand perhaps what you could have done different or what you did wrong. And I think for me, that always makes me sad when I hear a patient talk like that, because you have to be able to realize, like, being fearful in an unknown situation is normal. Okay. It's normal to have, and for moms to have anxiety when they show up in labor is a normal thing because it's a new experience. And what I like to tell them too is each time it's different. So your second birth story, your third birth story, they're all going to be different. And so I think it's just, what can we do to make you comfortable to allay that anxiety and that fear? And I think that's where some of the trust has to come back with the medical community, with, the OBGYNs, so that patients, can kind of surrender that fear and be able to realize, like, it's not all on you. You know what I mean? Like, we need to empower you so that you can be able to have the experience that you want,
Well, I'm so glad you said that, because that's exactly what you did. I moved into my third trimester and we started, and I'm going to leave you to the details. We started doing NSTs, non-stress tests.
Right, non-stress tests. Mm-hmm.
Yeah. And because of my traumatic birth with Sebastian and some perineum issues, there was a point at which you were like, enough stairs from the beach to the parking lot at Strands, enough hardcore working out. Let's keep the baby healthy and safe and inside you. And I took it easy and I just started walking, and then we started non-stress testing. So what's the purpose of an NST? Why did we start doing that? What were you looking for? What can you garner from those results other than what we see, which is just the heart rate going up and down?
Yeah, no, that's a wonderful question. So non-stress testing, or what we call fetal diagnostic testing, is a way for a physician to get an idea of how your baby is coping inside the uterus and how your placenta is maturing or aging, and if it's actually supplying the baby with everything that it needs. So we know, and I guess I can use your details. In your case, you had advanced maternal age. Okay, so that was a factor. Any women over the age of 35 is considered to be of an advanced maternal age and at higher risk for pregnancy complications. Perhaps it could be, because mom has gestational diabetes, hypertension, for any type of what we consider a high risk pregnancy. Or if mom is even low risk, but comes in and says, gee, I have decreased fetal movement. So for a variety of reasons, we'll do what's called fetal diagnostic testing. And the simplest, easiest way to do fetal diagnostics is to combine a non-stress test and an ultrasound that we call an amniotic fluid index, where we look at the amount of amniotic fluid surrounding the baby. That tells us if the baby has a healthy environment to move around in. And it also gives us a hint at the placenta's aging process and whether it's, providing what it needs to the baby. It gives us a little bit of information on mom's hydration status. And then the non-stress test, you're right, is looking at the baby's heart rate in response to movement. And so there are patterns that we look for when we look at that non-stress test. And a perfect non-stress test will take about 20 minutes. And in that 20-minute interval, you want to see a certain number of what we call accelerations, where the baby's heart rate goes up and above, at least by 20 beats above whatever its baseline is. What we don't want to see is the baby's heart rate decelerating or going down or below that baseline. And looking at those patterns, we can get a sense for if baby is showing any signs of distress, if there's any premature aging of the placenta, if there are subtle signs to us that perhaps the baby being in utero it's starting to get to a point where we walk that fine line where maybe being delivered would be more optimal than staying in utero. And it's always best to let a pregnancy continue as far along until, Mother Nature or its body's ready to, start the birth process. But what we've learned from years of experience is that there are signs to us with that type of fetal diagnostic testing where we can say, we can avoid some complications that we see with advanced maternal age with, low fluid or oligohydramnios, hypertension, different things like that with doing what we call, delivering you at an opportune time.
I love that.
And so that's why we were doing the non-stress testing in you, to be able to, figure out when would be the best time to deliver Kelly. I think a factor in your first delivery was that a lot of the research or study shows that the optimal time to deliver a mom in her first pregnancy, most first pregnancies, moms go late, so they go past their due date. So having what we call excellent dating is really, really important so that you have the proper visits in your first trimester and you can establish that your dates are excellent. And then when you know that, we know that somewhere between that 40th and 41st week is the perfect or optimal time to deliver a mom because baby doesn't get so big that there's a chance that it's too big to fit out vaginally. And your body's also ready for that delivery. When you go from the 41st to the 42nd week, the chances of having a C-section kind of actually go up because your baby's getting larger, may not fit through the pelvis. So there's a lot of factors that go into play to picking that optimal time. And in your case, you had gone beyond your 41st week.
42.
Your first, yes.
8.6 pounds.
Yes.
4 hours of pushing.
Yes. So all of those are factors when you look into. And so, recognizing that we were trying to accomplish a different birth scenario than you had previously, I knew that delivering you before your baby got to 8.5 pounds and was post dates was going to be optimal. And so those non-stress tests were our sign of what was going to be opportune. And in your case, there were some indications on your non-stress testing that particular day that showed us that perhaps, it was time. And I think something that kind of speaks to that was you had a very short labor course. So once we got you to the hospital, once we started your induction, 5 hours later, you delivered a healthy baby. So that showed us your body was actually ready and it was time. Yeah.
No, it was wonderful. And can you talk about they looked like hash lines on my non-stress test. And what we had ended up doing, you sent me to ultrasound to look where the cord was. And then after birth, we realized the length.
Yeah. Yeah. So a lot of different factors that go in, but one of the, you often hear people talk about a cord wrapped around the neck. And is that a reason you have to do a C-section? And, I like to tell patients, and I almost don't like when they hear, in an ultrasound, like, oh, it looks like the cord's wrapped around the neck, because really we deliver a lot of babies vaginally with the cord around the neck. And, there's maneuvers that the physician does to make sure that, everybody's safe and you reduce the cord, and that's fine. But our concern is if the cord is around the neck or even around a leg or wherever it would be, and it's tight. And so we can sometimes, when we're doing the monitoring of a baby, we can see signs of when, there's cord compression or the cord is being squeezed. And so sometimes a cord around the neck or a cord wrapped somewhere can be a problem. Or in other cases, and in your case in particular, a short cord can sometimes be an issue. So if cords are too long, babies can get wrapped up in them. If cords are too short, when you're starting to contract or go into labor, or as the baby is descending in that final stage of labor, there can be some, pulling on that placenta, and you can see signs of early distress, and that's because the cord is so short. And so those are all things that we look at, and we were able to have kind of an answer as to why your non-stress testing was looking the way it did. And it was probably because the cord was short. And so had you had a longer labor, or had you labored where we weren't monitoring things, we might have seen more distress than obviously we wanted to.
Yeah, absolutely.
Yeah.
Well, it was interesting because we were planning to, I had asked you, obviously, I didn't want to go as long as I did last time. I really wanted to err on the side of caution. I was really open to induction this time. I just wanted to have someone else have control over my labor.
Right.
And that's what we had planned on. And you were open to that. Can we talk about induction for quote unquote geriatric pregnancies?
First of all, I have to laugh. I don't know why, but I feel like it's more so in this last year. Patients are all coming in, they're saying geriatric pregnancy, and I laugh and I say, who called you geriatric? Like, we've never done that. So I literally, when you had that on your list, these are some questions I want to ask you, Dr. Karamardian. I literally Googled, this morning, geriatric pregnancy, because I wanted to know, where is this coming from? There's so many people using that terminology now. And what I looked up, it said pregnancy at an advanced maternal age, which is 35 or greater, is associated with higher risks and stuff. But it actually said that nobody calls it geriatric pregnancy. We call it advanced maternal age. And so we've stopped calling it that. Now, I wasn't going to tell you how old I am, but you obviously know the age of my children and stuff like that. So with my 29 years of experience of doing this, I've never heard anybody call it geriatric before. So it's really funny to me that it seems to be like the buzzword now. Yeah. And I think it just sounds really bad. But in professional terms, we call it advanced maternal age. And pregnancies of advanced maternal age, which, by definition is 35 years and older. But it's funny because if you look at some of the research and stuff now, they talk about women 37 years and older. And I laugh because I myself am, older or geriatric, whatever you want to call it. And I think to myself, nothing really changed with those stats. But I think we have so many women having children so much later in life now that we kind of raise the number a little higher. Like, we don't have to worry so much about those 35 to 37-year-olds, but the 37 and on is where we'll really pay attention. And I think it really has to do more with resources and volume. But basically, as a woman ages, obviously her fecundity or fertility declines as she gets older. Are really in your 20s and early 30s is when your body is primed to do this. But, women are doing a lot of things now. They're not just having babies. And so with work and everything else, they're making those decisions to have their families later on in life. So what we're seeing is a lot of women of advanced maternal age having their children and recognizing that does put you at risk of preterm birth, low birth weight, stillbirth, chromosomal defects, labor complications, higher risk of C-sections. That sounds like a really bad list when I just read that off, right? It's like, oh my goodness. And you think about all those things. But okay, so everything we do, we kind of laugh that, everybody would love to do low risk obstetrics. That's the easy thing. Stand there with your catcher's mitt, catch the baby, and everything turns out fine. And 99% of the time, that's the way it is. And it's low risk until it becomes high risk. So those things I just rattled off they're things for an obstetrician to pay attention to, not a mom to worry about, but then for us to know so that we can help guide you. And so they're all things that can be mediated and, improved by, nutrition and lifestyle and kind of working and cooperating with your physician. So, I think advanced maternal age pregnancies or geriatric pregnancies are higher risk, but in our demographic and in, my practice, they are more the norm.
Yeah.
And so it's something that we just have to, work with. Yeah.
Would you say that when it comes to advanced maternal age and induction, what is the literature saying in regards to if people should be induced or not?
Yes. Yeah. And even there's recommendations specific to age ranges. And so, yes, because we know that the placenta ages more rapidly in a woman of advanced maternal age, all of those factors I talked about, doing the fetal diagnostic testing, all of that comes into play into picking the opportune time to deliver someone. And so I like to tell my patients that I want to, you want to work with them. So if a patient is doing fetal diagnostic testing, that's where this kind of becomes a little bit of an art and not just a science, but putting all the information together and trying to pick out what is the perfect time. We know that somewhere in that 39th to 40th week is the opportune time for a mom of advanced maternal age to deliver. But we start our stress testing earlier on, and we do that because there might be indications or those particular cases where maybe intervening sooner would be the case. And again, if everything is going along beautifully and the testing is fine, is there room to, let a mom go a little further because perhaps she wants to try to deliver vaginally and her cervix is not ripe or inducible? And I think that's the other thing too, is recognizing that not all inductions are the same. And so I think patients get scared. And there's a lot of misconception out there about induction. And I think recognizing that when you just say the word induction, I mean, you can be talking about apples, oranges, bananas. I mean, there's a variety of different reasons why certain things are done. And if you go back to your birth story, I almost feel like it really wasn't an induction. It was almost an augmentation, right? So you were already dilated. Okay. The head was already well applied to your cervix. You didn't need any cervical ripening agents or things for me to give you to induce you. Okay. So you were inducible, like we like to say. And there's actually a whole scoring that we have where we look at the consistency of your cervix, the position it's in, how dilated you are, the position that the baby's head is in. And so all of those are factors in determining when that number gets to a perfect point, and it's called the Bishop score, then we decide this is an opportune time to induce someone. Now, obviously, if there's some maternal or fetal indication to do it before that, you just know that you're starting with an uninducible cervix and you have a bigger job ahead of you. But in your case, you were dilated, your cervix was soft, the head was in position. So we really kind of augmented you with Pitocin to get you into labor, and then did that active labor management where we broke your water to then, have you deliver. So there's different types of inductions. There's different reasons for inductions, and you're starting at different points, and I think, as we mentioned, like Pitocin, I think Pitocin has a really bad rap out there. And a lot of times patients are like, oh my goodness, whatever you do, Dr. Karamardian, I don't want Pitocin because Pitocin really hurts. And I have to explain to patients, okay, where did that concept come from? Let's talk about this, because I think when I explain to a patient, when a patient comes in active labor on her own, usually she comes in because she's in pain, right? That's your cue to come in. Okay, they're breathing through their contractions. They're 5 minutes apart and they're really feeling something, right? They get checked in the triage area. Yes, ma'am, you're in active labor. Let's get you the labor room. Let's get you moved in there and let's have a baby. Nobody ever goes through that process and, is like, gee, check me. I don't know if I'm in labor. And, I don't feel anything. You're feeling something, when you're in labor. And so, and that's, joke patients will be like, will I know when these contract? I said, oh yes, you won't be able to talk through it and you'll know. That's why your husband will be calling me as you're driving in the car. So, you have a sense that something's going on. When someone's being induced, and say perhaps if it's within Pitocin or Cytotec or, whatever the method is that we're doing, you're going from not being in labor to being placed into labor. And labor is what hurts. It's painful contractions that, are changing your cervix. And so I try to explain to patients that it wasn't the Pitocin that hurt. It was the state of being in labor, or what we're trying to achieve. We're trying to mimic, labor and get you into that. And a lot of times you'll be given these in agents, and then we'll even shut them off. You know what I mean? And that's the beauty of Pitocin over some of the other agents that we use. Other things can't be removed from your system, but the Pitocin is going through an IV and it can literally be shut on and off. Whereas in some cases, that's even scientifically, it's easier for us to manage than a natural labor. Sometimes women will come in and they'll be having one contraction after another on their own. And, that's difficult for us to manage or stop. And sometimes it's a little too much stress for the baby. But with Pitocin, we can control how we're giving it, the amount we're giving it, and we can shut it off. Yeah. So that's the beauty of it. Yeah.
Well, it's so interesting. I'd love to talk about Cytotec for a minute, because I know that some people get that too. And I believe there are multiple ways to use that.
Correct.
But going back to the Pitocin thing, I was always afraid of pit pain. But I had decided based on my last birth, my wish was, please evict my child at 38 weeks and quickly. So you were always like, we'll see how you're doing and I'll let you know when we get there. And I had to wait patiently until I got close to that 38 weeks, and we did swipe my membranes, and then we looked and everything kind of just progressed the way it naturally did. But when I got to the hospital and was finally checked in and hooked up to the Pitocin, I started contracting, or when I got checked in, I started contracting on my own. I think it was, my body was like, I'm in a safe place. People are safe here. I'm safe here. They're going to take care of my baby here. He's being monitored here and everything's okay. And it was amazing because my body just naturally kicked in right after being checked in. And you ended up putting me on Pitocin. And Chris was really worried. He was so petrified of the pain that he saw me go through the first time around. Those awesome 16 hours for him. Yeah. He didn't want to have anything to do with that. He didn't forget it.
Yeah. No, yeah.
You didn't. And you have to think about your partner in these situations too. I mean, you both are having a baby together. You've been married, or they're your partner, but you're starting a family together. And that was, this time around, I was really cognizant of the toll it took on Chris to watch me in so much pain for so long. And then to watch the aftermath of me dealing with my son being in the NICU and all the things associated with that. You have to look at the whole picture. And so I remember you put me on Pitocin in every 5 minutes, and it was so low. I mean, I was already starting to contract. And I think that that's the beauty too, is you can really change the dose, and you have so much control over that. And he's like, are you in pain yet? Are you in pain yet? I'm like, no, stop. We're like, I'm clearing out work emails because I was supposed to be induced on Saturday and it's Tuesday, because I ended up being sent after seeing those after the non-stress test. And I love that about you. It was like, we had a plan, but you were like, you know what? Nope, I'm taking over. You're going right now. And Chris and I had packed our bags that day, and you'd let me know to do that. And just in case, because you weren't liking some of it, but that was so nice for me, because I did get the Pitocin. I did start to feel the contractions, but nothing was unmanageable. It's like, it was allowing the body to do its thing. And
I think too, it's recognizing in those different scenarios. Like, I think in your first case, you said your physician came in after 16 hours and said, I really think you should try to get an epidural if you want to deliver vaginally. And so many times we find patients their bodies are so tense and they're so anxious or tense, for lack of a better word, when they're in those early phases. And it's amazing when they'll get an epidural and they'll just completely relax. And then all of a sudden you see this great change in their cervix. And so that's why when patients are like, oh, I was told I don't want to get an epidural because I hear it slows things down. And again, I feel like you have to look at the scenario. You have to look at the story that the person's telling you, and you have to kind of break it down and analyze it. But in some cases, someone's, given an epidural because they've had such a long labor and they're exhausted and they can't handle going much further. And maybe the writing was on the wall that that baby just wasn't going to fit, like in your case, with your first. But in other times, you can use an epidural, completely relax, and see that, the dilation is just, falls off the labor curve the other direction. It's like, whoops, got to get my gloves on. It's showtime, So it's recognizing what that patient needs and where she's at, and kind of helping to explain that to her. So I always like to tell my patients when they say, when is the best time for me to get my epidural? And I'll say, probably whenever the nurse offers it to you. If that is before you think you need it. And they look at me like, what are you saying? And it's like, well, when you need pain relief or you want it, I want you to ask for it. And so, then obviously we'll have a conversation of whether or not that's a good time. Might be too early. Maybe you're asking for it out of fear. There's other things we can do to manage or control pain. But if the nurse is saying to you, would you like to get your epidural now? That's usually a signal that she's seeing signs that things are about to really take off or escalate. And it might be an opportune time for you to do that. And so it's recognizing those cues and using these treatments to help afford the perfect outcome, like what you want. Yeah. And so I tell patients, like if I was a dentist, you wouldn't ask me to pull your tooth out without giving you some form of anesthesia for it. Do you have to have that? No, but there's some scenarios like the twins I delivered last night. We always like to have some type of regional anesthetic on board with twins because of the risk of second twin flipping, having to do an emergency C-section, baby's heart rate dropping, going into distress. We're not sure what we're going to encounter in a twin delivery. And so I like to encourage patients to have that, especially if I have to reach my hand inside, do a breech extraction, whatever the case may be. So there's certain scenarios where it can really make a huge difference.
Absolutely. And I think you being informed and being erring on the side of caution and safety and just health outcomes, that really needs to be the goal. I think obviously based on my situation, but it also really is, it can be a beautiful experience. And going sort of back to my birth story, Chris being afraid of us, me being in fear, you had said, I think I was like getting close, like 70% effaced. I was like 50% effaced or something like that when you sent me over. So we knew we were good to go. And 3 or 3.5 centimeters dilated already. I was like, let's have this baby. Yeah. And so you're right. It was like you augmented it. And the Pitocin really helped soften my cervix. And then you were going into a C-section. So you popped over and you're like, do you want me to break? I'd like to break your water. Do you want me to break your water now? And Chris was petrified. He was like, she hasn't got her epidural yet. She needs, because he was so afraid you were going to break my water. And then there wasn't going to be enough time for an epidural. So I think we probably could have had Taschen on the 24th of November had he been open to me getting my water. I was like, we can do it. I already did this for 16 hours. I'll be fine. And he just really asked me not to. So I ended up getting the epidural. And then you broke my water. And I watched The Bachelorette in the room. And we turned it off. We turned off the lights. And Chris and I held hands and kind of just like, we're in the dark for a little bit. And the nurse checked me and I was still like at that 3.5, but I was going from 90 to 100% effaced. And in 45 minutes, I went from 3.5 centimeters dilated, which is what I was in your office that morning, to 10. And we had to call you out of your bed.
Yeah.
Have you come catch the baby? So can we talk about breaking water and when to use that? Because I have had friends in the past, like I told you before we started, who were on Pitocin for 24 hours, maybe weren't in the right place to be induced. They called it false labor and they were ready to send her home. Ultimately ended up breaking her water. But when would someone use that? And I think people are like, don't do that because you're going to induce bacteria, or don't do an epidural because it's bad for you and the baby. Can you kind of demystify some of these myths that people have around these things?
Again, I think there's just, it's everybody has a birth story, or multiple birth stories. And it's looking at those individual stories and looking at the details. And so that's why when patients will say, oh no, my girlfriend told me this, or, oh no, my mom said that. And I'll say, well, tell me a little bit about what she said. Tell me the scenario. And you can generally kind of understand or grasp, a bigger picture and what was going on at the time. So breaking your water, or rupturing membranes, as we call it, is a form of what we like to call active labor management. And there was actually a lot of research done in Ireland on how to actively manage labor, and what were things that could be done or accomplished to increase the odds of a vaginal birth as opposed to cesarean section. And in Ireland, they have really good vaginal birth rates as opposed to the C-section rates. But again, that's we could do a whole podcast on that. It's a whole conversation about, looking at demographics and risk factors and things for cesarean section. But when you are actively managing someone's labor, breaking the water can be a part of that. And it's a tool that can be used. And yes, it does hasten. It increases the uterine contractions, and it hastens the labor, and can be very helpful. Again, it has to be done at the appropriate time. So looking at the scenario, is the baby's head too high? Is it unsafe to break the water because maybe a cord or something else might slip down, and it's not quite time or ready, but breaking the water can give us cues as to whether or not there's meconium in the fluid, and whether or not the baby has had distress. So when your water has been broken, we can also put in special monitors into the uterine cavity, and we can actually introduce fluid. So sometimes we'll break water and we'll put an intrauterine pressure catheter in. So because we have maybe been inducing someone because their fluid levels were low, because I talked about how the placenta was prematurely aging, or they weren't producing enough fluid around the baby, and we want to do what's called an amnio infusion, and we introduce normal saline into that cavity so the baby has a cushioned environment to labor in. So there's lots of tricks and things that we'll do to increase the odds of being able to have a successful vaginal delivery and make things safe so that a baby can be inside the uterus and be tolerating contractions and not getting squeezed maybe too much. So there's a variety of reasons why we would break water. But again, yes, anytime the membranes are broken, and that's happened, there is the opportunity for bacteria to be introduced into the uterus, and for baby and mom, to get infections. And so you want to time that just perfectly so that a mom perhaps doesn't, get an infection. And you also want to make sure that if mom, say, is a beta strep carrier, and that's a particular bacteria that we look for in the last month of pregnancy. There's kind of this misperception. People think, oh, what is that? When you tell them, they have beta strep in there. Everybody's flora or body is made up of all different kinds of bacteria. And we just recognize that certain bacteria, when they're in the vaginal canal and a baby is delivering through the birth canal, can cause problems sometimes to the baby. So we're not trying to clear your body of any particular types of bacteria, but what we want to do is not introduce certain types of bacteria into the uterus, or to have the baby deliver through a vaginal canal that has high volumes of certain types of bacteria. So again, taking probiotics, there's a lot that we're learning about the microbiome. And that, I think, is probably the most interesting data and stuff that we have now in our area of OBGYN, is just learning about your gut health and learning about taking probiotics and learning about how all of that impacts your unborn child, and the beauty of delivering through the birth canal, of having, the baby's lungs squeezed and the fluid coming out of it, and how all of that even impacts your risk of asthma and other issues later on in life. It's amazing, And so, yes, so breaking the water is a tool that we use. It can be used to help augment Pitocin. It can be used to help prevent you even needing Pitocin, because that alone can help move things along. So there's a variety of reasons when or how we would do that.
because I never received Cytotec.
Cytotec, yes.
But I was told about it previously, I think in a birth class up in Los Angeles, before Sebastian was even born. I believe it was a dissolvable tab and a intravaginal.
Right. So the same tablet can be, it can be used either. It can be placed vaginally. I love the Cytotec story just because it's a USC story.
Yeah.
And so I actually was a intern, and just in my beginning years at USC when a maternal fetal medicine specialist, her name was Dee Wing, was actually one of the ones who started all of the research and looking at dosing Cytotec and using it to induce labor or augment it. And it was quite a wild ride because we started off with a typical dose. And, and as in most things in medicine, it was kind of like just sort of picked up serendipitously, like that could this medication, which actually is a medication for GI issues and ulcers and stuff that is used. But they found that women who took this early on and not realizing they were pregnant would have miscarriages or abortions. And so they realized that it was causing uterine contractions. And so that was the first clue that, maybe this drug, which is otherwise completely safe because we use it for women to treat GI issues, if we could give women that drug at the end of pregnancies to stimulate contractions, is that something that we could use that would be different than Pitocin? And so the beauty of Cytotec is that it is a tablet that you place, we learned, under the tongue, or as we found with studies, was tolerated the best when used vaginally. And so we, started off with big tablets that then got cut in half, and then we cut them in fourth because we were finding the opportune dose. But that Cytotec helps to soften and what we like to say, ripen your cervix. It also stimulates contractions. And so it's a good tool to use early on to help get someone to a point where then they can be dilated and then maybe their water can be broken and stuff. So there's a variety of reasons. But for patients who have a firm, unfavorable cervix, that's something that we like to start off using. Interestingly, we found that this medication also helps to contract the uterus down. And when moms are having issues with postpartum hemorrhaging or bleeding, we use that medication again. So we found a variety of uses for this medication, and it's become one of the mainstays that it's really kind of been a game changer for us to be able to use it to prevent women from hemorrhaging, needing blood transfusions, things like that. And then also on the other end, to help establish labor. The drawback with Cytotec is obviously that once that tablet is dissolved and in your system, it's in your system. So again, one of the beauties of Pitocin is that you can shut it on and off because of that IV route. And so you don't have that same sort of control with Cytotec. And so you have to weigh whether, which agent is the right one for the patient.
Yeah, definitely. Well, I was really happy with the way that I was induced, obviously, because I did have a healthy baby on my chest within 5 hours. And we had that beautiful skin to skin moment. And really, the room was quiet. And it was, when you came in the room, I know I had 2 contractions and 4 pushes, and I had a baby. At one point you looked at me and you were like, slow down. I think I felt like I needed to push as hard as I did last time. And if people heard my story, the time obviously with Sebastian, I had broken every capillary, like in my eye, in my face. My face was red and bruised days after my birth. Like,
it wasn't for lack of effort that it took so long to get him out. Yes.
And in this time around, it was, he came out upset. And that was funny. We always said was, I remember Chris and I went on like our first date in forever. And we had gone to Malibu Farm and we had decided to name Taschen Patrick, which is Chris's middle name. And Chris is really artistic and Taschen is after an art publisher and like a world renowned art publisher. But we had named him. And then I remember Chris just being like, I just want to hear him cry. Like, I want to hear him wail and scream. And then we couldn't even talk because he was yelling so loud.
You got your wish.
We got our wish. We got our wish. And the things we got to worry about were the things that most parents get to worry about. Was not like the health and safety of our child, but was, making sure we filled out our birth certificate information right, and making sure that I was healing right. And what were we going to order from DoorDash to our postpartum room? And we got to worry about the things that most parents worry about. Like, will these nurses stop coming in and bothering us so we can actually get some sleep? We're not going to get any from here on out. So it was exactly what we wanted, and such a beautiful moment. And I do remember like being full of tears and looking at you and just like being so beyond grateful for a really healing moment for me. Something that makes me want to continue to have my basketball team of kids, 3, 4, 5. I mean, we'll see what Chris is up for, but these babies are such a gift. These children,
they're a blessing.
They teach us so much. And now I'm going to cry, but we had like a really,
you're making me cry.
we just had such a beautiful birth story. And it was really healing for Chris and I. And Taschen, he's our little healer, and Bash is a basher, and he challenges us every single day. And he's so much fun, but Taschen is, you have 2 boys, like their personalities are so different.
Yes.
And what we get from each of them is so different. And Taschen is he's my cuddle bunny. He's my little smush. He's my boyfriend. Like I'm a pushover for him because he healed me the way that he did. And you facilitated that for us. And I couldn't be more grateful. I can't thank you enough.
You're welcome.
I'm going to deliver all my babies. So.
You're welcome. I'm here. I'll have my catcher's mitt on.
Okay, good. Well, that being said, if someone is thinking about having children back to back, if they're later in life or post, advanced maternal age like myself, what are some postpartum support? What should we be thinking about in regards to timing between children? I know you and I talked about postpartum PT, hyaluronic acid suppositories, telling me to be
so
careful.
Much to talk about. Yeah.
We can keep it short. We can do like your hit list. We can have you back when I'm getting ready for
number 3,
pregnant with number 3. But are there any like top line things that you want moms to consider if they've had a baby? What are some resources that they have, and when should they be thinking about?
Yeah. And I think you and I have talked about this. Our group, we like to call ourselves PACWA, or Pacific Women's Healthcare Associates. We have been working during this last year with COVID, trying to develop some more dedicated and customized programs for women to address all of their needs. I think we saw a lot in this last year during the pandemic. There was a real beauty for our pregnant families to just kind of slow down. And there was a lot of good that came out of some of this isolation, and a lot of beautiful, what we saw, bonding between moms and dads and babies, and really getting back to maybe an older kind of lifestyle where we kind of slowed down a bit, not having 100 people in the delivery room and things like that. Really created for some very beautiful moments where dads got to kind of be themselves and got to really participate without a bevy of maybe other women in the room, drawing attention to a tear in their eyes or whatever the case may be. So a lot of that was really good. I think patients started to do a lot of self-care, pay attention to their nutrition and things like that. But then I also think on the other end of it, postpartum especially, I think isolation, can really have its toll. And so while I think it's important to cocoon a newborn, during those first 6 weeks and to make sure that they're in a safe environment, I think one thing that we recognize is, and an area that's really being looked at now, is what we call trimester 4. and looking at that postpartum period. And I think if you look at women in Africa or even some of the Asian and Latin American communities, there's really more of a sense of community as a whole, with an entire culture of families kind of coming to the aid of moms. I think a lot of patients are, aware of what we call doulas now. And that word actually came from the Greek, where it's mothering the mother and providing aid for postpartum moms. And so I think being able to anticipate physical and emotional needs of moms in this fourth trimester is really important. And I think looking at ways to help moms rehabilitate, postpartum PT, to look at the pelvic floor and things like that, recognizing that vaginal dryness is an issue. Sexual intimacy can have its, roadblocks and stuff when you're breastfeeding or, have scar tissue and things from a vaginal delivery. So just anticipating all of those things and having resources available to the moms. But I think more importantly than anything else is just recognizing that this isn't something that you have to do alone or that you should do alone. I mean, it really does kind of take a village, so to speak. And I think more so than in any other time, you really need to look at, the resources available to you and to be open to reaching out and realizing that you're not alone. And in no other cultures or places are women expected to go through this time alone. They really have a lot of help, and we need to make sure that those resources are available to moms, so that it's readily available to them. So I think that's the most important thing is speaking out, letting your healthcare provider know what your needs are. And it can be as simple as just offering advice as to postpartum, just easy nutrition and being able to get the right amount of rest and things like that. But, or, down to as intimate as, looking at, like we talked about, the hyaluronic acid suppositories that are a natural way to deal with vaginal dryness, lactation support, things like that.
Yeah, I echo what you're saying. I think for me personally, not as much after this delivery, but after my first, obviously, I reached out to a family and marriage and family therapist that was for trauma and loss. Mm-hmm. I had my Mommy and Me group. These were the things that I think I would be falling apart if I didn't ask for help and I didn't, have, a kind of breakdown of what my birth story was with my OB. And I had things that I needed to do to get through. I had a lactation consultant come to our house because I had, Bash was being fed TPN and then he was given my breast milk in a bottle, but he had never learned how to latch. And it was at 6 and 8 weeks that we were really working that out. And I needed major support. So gosh, I mean, I completely agree with you. I think in the postpartum, especially their first time around when you don't know what to expect, asking for help and reaching out and just knowing that, especially in my Mommy and Me, just telling our birth stories, telling what we're going through. It was always what's going great right now? What's not going great right now? And the right now was always mandatory because nothing lasts forever. And that it was a stage in which we all needed to get through. And so I love that you encourage people to reach out and ask for support because there are so many things going on and so many changes. And I love that you're such a resource for me and that you've become a resource for my community. I love that we've got the chance to introduce you to them today. So thank you for being here and
thank you.
Sharing so much great information. I know that people will be so excited about this episode and want to hear more and to have you back. And we'll find time for that the next time around. But for anyone listening, where can they follow along on social media? Where can they find you on your website? Where at Hoag, all the good stuff.
Our group, Pacific Women's Healthcare Associates, can be found online at www.pacwha.com. I do have a very limited social media presence on Instagram, Dr. Lisa Karamardian. And we practiced out of Hope, Newport Beach. So we exclusively do our deliveries at the Newport Beach campus so that we're always in one place and ready and not going between the different campuses for our patients. But yeah, so just practicing here in Newport and looking forward to continuing to help grow your family.
Yeah, I can't wait. Well, I can because I'm still,
you're still sleep deprived.
I'm still in the throes of sleep deprivation, but we're working on it. So we'll keep you posted.
Okay.
Gonna get through 2021 before we go there. Yeah. Well, thank you, Lisa. I appreciate you so much. I'm so excited we were able to find the time to do this. I hope you have a nice, restful day. I know you worked overnight last night and we just used your brain for over an hour. So I appreciate you so much and love you. And I can't wait to see you again. I'll see you at my yearly.
Yes, I'll see you then. Thank you. All right, honey. Take care. Bye-bye.
Thank you for listening to Be Well by Kelly. Please subscribe to the show on Apple Podcasts, Spotify, or wherever you listen to podcasts. Learn more at bewellbykelly.com and follow me on Instagram at bewellbykelly. I would love if you picked up my books, Body Love and Body Love Every Day. They're sold on Amazon and at all major booksellers.